Hello, dear colleagues and dear members of the organizing committee and the scientific committee. Thank you for the invitation to talk about the urgent need to implement patient blood management. Before I start, here are my disclaimers. I'm working for governmental and public institutions, professional societies, and NGOs, blood services, and sometimes with and for the industry. And I'd like to start with a slide that shows us a huge global challenge. The patient's own circulating blood is the most neglected organ. And you can see this from this graph. It shows you 2.9 billion individuals worldwide are suffering either from anemia and or micronutrient deficiencies. And then you have an overlapping part of about 600 or more million individuals with chronic or acute blood loss and bleeding disorders. According to the WHO, taken together, they represent one of the world's biggest, largely preventable, and yet greatly underestimated public health and health economic burdens. Now, if you look at this from a surgical perspective, we have three drivers for adverse outcomes in more than 300 million major surgeries. In fact, I think currently it's about more than 400 million because these data are relatively old from Rose and colleagues in the Lancet 2015. However, we look at anemia and iron deficiency prevalence is somewhere between 20 and 75% in hospitalized patients, and then between 6 and 12% prevalence for blood loss and coagulopathy with bleeding in cardiac surgery. The percentages are even higher. And these three problems, A, B, and C, anemia, blood loss, and coagulopathy, they are depicting the triad of independent risk factors for both morbidity and mortality. Now, anemia per se is a killer. Here's a meta-analysis of the association between pre-op anemia and mortality after surgery in almost 1 million patients of 24 studies, of which 39% in these studies patients were anemic, and the anemia was obviously a driver for mortality, a 2.9-fold increased risk, almost 4-fold for acute kidney injury, twice as many hospital-acquired infections. In a subpopulation of cardiac surgery patients, the increased risk for stroke was up almost 30%. And of course, the anemia is a major driver for red cell transfusion. The same picture, if we look at women anemic prior to gynae surgery, similar drivers for mortality and other complications. And we should keep in mind that 50 to 70% of females presenting for gynae surgery are anemic. Now, if we come back to our model, then we know for the last 60, 70, 80 years, the default treatment for A, B, and C was and still is in most situations transfusion. However, transfusion is charged with loaded with a lot of complications. Here's some recent large observational data from Susan Gooby and James DiNardo from Harvard, champions for patient blood management in the field of pediatrics. And they looked at the association between pre-op anemia, transfusion, and outcomes in children undergoing non-cardiac surgery. This is just one of 50 to 60 large observational studies with more than 10 million patients, always showing the same pictures. Now let's have a look here at these 429,000 kids. Incidence of 30-day mortality with no anemia, 0.08. With no anemia but transfusion, it's 0.3. And the question arises, why would they have received transfusions when they were not anemic? And then there's the next bar that shows you anemia without transfusion. Mortality is 0.27, but then with anemia and transfusion, it's 1.11. Now you might say, well, this is observational. Um, it is. It's also corrected for a number of confounders to make the multivariable logistic regression analysis. But what about randomized controlled trials? Well, let's go back 27 years to the famous TRIC trial, which looked at liberal transfusion strategies versus restrictive, less than 10 versus less than 7. And you can see that during hospital stay, mortality was significantly lower in the restrictive group. Patients younger than 55 years had a lower risk of mortality, and patients with Apache 2 score less than 20. Um, Also, multiple organ dysfunction score was in favor of restrictive, and myocardial infarction and pulmonary edema. Now, it took almost a century after Landstein's discovery to test the efficacy of transfusion, and the results were counterintuitive. However, my colleagues and I came to the conclusion then when we look at restrictive versus liver transfusion trials, are they asking the right question? Because these trials are not testing the efficacy of transfusion, which would be red cells versus placebo or another intervention. What they are testing is anemia tolerance at different levels with subsequent transfusion. And so what my colleagues and I did is a systematic reviews and meta-analysis comparing mortality in restrictive and liberal HB thresholds for red cell transfusion, an overview of systematic reviews. So in fact, we looked at 19 systematic reviews at the time. This was in 2020. And you see the turquoise are the restrictive thresholds, and the pink are the liberal ones. And you see this is here from 80 to 100 to 120. Most of them are overlapping, which is not really good to answer the question of efficacy. However, there was one systematic review that's stuck out because it had the largest difference of thresholds. You see, there's a huge delta between the two groups, not overlapping. Here, less than 7 versus more than 9. And this were, in fact, the TRIC trial. Then also the colleague from Paul Hébert in Canada, Jacques Lacroix, in the pediatric ICU, and then the Villanueva study on acute upper gastrointestinal bleeding. And when you look at these, then you see that the total mortality risk ratio was 20% lower for the restrictive group, and also for in-hospital mortality, rebleeding, ACS, pulmonary edema, and bacterial infections. They were significantly lower in the restrictive group. The number needed to treat with a restrictive strategy to prevent one death was 33, and the authors came to a very sobering conclusion. With millions of transfusions given yearly over the past century, it would be hard to calculate how many deaths may have been caused by transfusions. Now, if we come back to our model, the default treatment, we have for years known there are direct transfusion risks, and they're pretty much under control. But now we see indirect dose response transfusion risk in a large number of studies. The more you give, not only by the way red cells, but also plasma and platelets, you see more mortality, cancer recurrence, hospital-acquired infections, morbidity, more renal impairment, etc., etc. And so this is also now a newly recognized medical legal implication. And what we have to understand is transfusion is not really the problem. The problem is the omission of managing A, B, and C. The upstream problem leads to the downstream effect, which is transfusions. And so we can say hundreds of millions of patients are exposed to one or more of these additive risk factors. And the statement that is almost ingrained in most people's and also physicians' minds, give blood to save lives, is outdated. In fact, we have to save blood to save lives. And the solution is called patient blood management, a patient-centered, systematic, evidence-based approach to improve patient outcomes by managing and preserving the patient's own blood while promoting patient safety and empowerment. And this has been driven by a number of entities and institutions and is now endorsed by a large and growing number. I think it's more than 100 now that have endorsed the concept, including the World Health Organization. Um, and it's based on the famous three pillars: the detection and management of anemia, and I would also include thrombocytopenia and iron deficiency. Pillar two, a minimization of blood loss and optimization of coagulation. And pillar three, the leveraging and optimizing the patient's specific tolerance of anemia. So the way to resolve it is to flip the perspective and to timely and effectively manage the patient's own blood, and suddenly you reduce the risk down here. And the only way to crack the triad is, in fact, the application of the three pillars. So we applied this in Australia a few years ago and had presented the results of the real-world study that included more than 600,000 patients with the fully developed and deployed PBM program. We started the program with the lowest red cell issuance rate of all high-income countries. So the stakes were high. We started with implementation in 2008, and as you can see, the red bars down here, we dropped it from 32 per thousand population to 19, which was at the time 2/3 below the United States. And the results were, of course, further reduction in blood product utilization. We had a lot less pre-op anemia because, the remaining 14% were only urgent and emergent cases, whereas all the elective cases were basically non-anemic because the anemia was taken care of before surgery. But what was most important is that we saw in that huge population a decrease of mortality, hospital mortality by 28%, infection rate by 21%, myocardial infarction and stroke by 31%, and hospital lengths of stay by 15% or 70,000 stay days. But what pleased the administrators so much is that at the same time, we had product cost savings of $18.5 million and activity-based cost savings of at least $80 million. And that was in contrast to a one-time investment of $4.5 million, which is an enormous return of investment. This and other developments led the World Health Organization to bring out the policy brief in 2021, titled "The Urgent Need to Implement PBM." And this has now been translated in other languages. And the policy brief also urges all member states with that call to action to act quickly through their ministry or Department of Health to adopt their national PBM policy and do all further necessary steps. Big questions that many are having is, how do you do this? How do you implement this? And for that reason, the WHO, with a group of 110 experts in the area from around the world, produced this guidance on implementing PBM to improve global blood health status, which is a new term, kidney health, heart health, but now we have also blood health because that is the therapeutic goal. And here is the implementation model. We call it the 8 model because it follows the shape of the figure 8. It starts with red and turns into green. Red is where the government basically prepares the healthcare system for PBM structurally. Then pilot projects need to be conducted, and then the national rollout should take place to make it a standard of care across the nation. We won't go into details, but I encourage you to download the guidance document from the web, and it has, in fact, 19 steps that are distributed between the government and the institutions. PBM is described in these documents as good clinical practice, starting with diagnosis, therapy, and follow-up, which is a much bigger concept than transfusion. It's just a therapy in most cases, by the way, without a diagnosis. The evidence is very strong. There's a large body of evidence, not just the Australian study, that shows that clinicians should adopt PBM and health authorities should mandate it. The economic argument is, again, extremely strong. And if these two are in place, then it's an ethical obligation to make it a standard of care ASAP. We call this the 3 E's of PBM: evidence, economics, and ethics. And if we come back to our problem that we started with, this enormous shared condition of about 40% of the world population, we have to say that from the epidemiological safety and clinical viewpoints, the patient's own circulating blood is the most neglected organ. The medical model to rectify this unacceptable situation is PBM, and the overarching goal is blood health. And so we have now, with this guidance, blood health as a public health goal, but also a therapeutic goal on the patient level care. To show you once more, or even more, how important this whole concept is, look at the hyperaging of the global society. This is the population pyramid in 2017, and this will be in 2100. We see that the octogenarians, for instance, would increase from 140 million to almost 900 million individuals. This is a generic problem for healthcare, but particularly in the field of transfusion medicine, because we know that up here, the majority of blood is consumed, about 2/3 in the group of 65 and older. And that has to be donated by normally people between 80 and 65. So the dependency ratio is probably tripling or quadrupling by 2100, and we already have chronic shortages, so we really have to change our mindset and treat blood as an organ with the same respect as any other organ system. And this can only be done with patient blood management. The World Federation of Societies of Anesthesiologists has taken on the concept, started with the Santa Cruz Declaration a few years ago, and in 2026 we had the 100th Anesthesiologist Society signing this Santa Cruz Declaration on fostering patient blood management. You see here Daniela Filipescu, the past president, and Carolina Halo-Clor, the new president, at the signing of the 100th society. Just about 10 days ago at the Marrakesh, the World Congress of Anesthesiology anesthesiologists in Marrakesh, there was the updated anesthesia volume that was totally dedicated on PBM. We know there's many clinical guidelines on PBM, and we had also in November 2025 a special issue in Analog that talked about or had many articles dedicated to PBM, and we can see worldwide that the penetration from 2008 to 2026 has steeply grown, and we hope to see the Ukraine on the map very soon. Redefining Healthcare by Michael Porter, improving outcomes versus reduced costs. Patient blood management improves outcomes for millions while saving billions. What's holding it up It's basically culture. So Yukiko Nakatani says, with the implementation of PBM, hundreds of millions can benefit, and we can reallocate limited funds to where they're most needed, because PBM doesn't cost you, it brings your money back. So thank you for your attention.